Hi, everyone. Welcome. We'll give it just a minute for everyone to get in the room and connected, and then we will kick off our session today. So welcome, welcome, welcome. As everyone's getting on for our session today, if you want to go ahead and put your name, organization, role where you're joining from in the state in the chat. We always love to see kind of representation of where everyone's at today. All right. Can everyone see my screen okay as well?
Yes.
Great. All right. We'll go ahead and get started. Welcome, everyone. I'm Elsa Staples. Work very closely with Andy Dwyer, and we're both representing the Colorado Alliance of Community Health Workers, Patient Navigators, and Promotores as kind of the state coalition for all of these roles in the state. And Andy and I also work at the University of Colorado on a number of other initiatives that support CHW patient navigator work and cancer screening work in the state. And we're really excited that you all are joining us today for the final session of our fall webinar series, which has really been focused on thinking about sustainability and reimbursement strategies for patient navigators and community health workers. And so today's session is focused on outside of those reimbursement strategies coming from Medicare and Medicaid, some of the performance-based and quality-based approaches that have been utilized to support sustainability of patient navigation and community health worker roles in Colorado. And we're really excited that we have some colleagues joining us from health systems in Colorado. So Mary Kay Canode from Melissa Memorial Hospital and Linda Overholzer from UC Health and CU Anschutz. So we'll introduce them further in just a moment, but want to get started with just a little bit of a reminder for those that aren't familiar with the Alliance about our work, the other sessions that have already happened in this series, and a couple of opportunities coming up. So just as a reminder of who the Alliance is, we are a nonprofit volunteer-led group that's really focused on supporting financial and overall sustainability for all patient navigator, community health worker, promotora, similar roles in the field, and really promoting resources and networking to support all of you in these roles and others who support them, and really thinking about overall how we can reduce and eliminate barriers to care, improve health outcomes, and really foster ongoing health equity to make sure everyone in the state has equal opportunity to obtain high quality healthcare and meet all of the full spectrum of their needs. So if you weren't able to join us for the other sessions in our fall webinar series, the first one was focused on the Medicare principal illness navigation and community health integration codes from CMS that have been made available through the physician fee schedule. So we have the slides recording linked here. We'll send it out in our follow-up email as well. The second session was really focused on Medicaid reimbursement and what to know to prepare for upcoming reimbursement implementation that will begin in July 2025 through Colorado Medicaid. So slides and recording are also available for that one. And our third session was really focused on some of the training, credentialing, workforce development opportunities that are happening here in the state, and really connect closely to some of the training and credentialing requirements for those Medicaid and Medicare reimbursements. So opportunities to get involved with the training side, and a little bit about different pathways. So find out more for that one as well, and we will share all of these links. And then November, can't believe we're already in November, but November is Lung Cancer Awareness Month, and National Lung Cancer Screening Day is coming up on November 9th. So the White Ribbon Project, which is an advocacy group in Colorado, is leading out a few different events this week, and wanted to share them with you all if you see opportunities to engage with them or want to share these with your networks. But they'll be hosting a ribbon building event in Greenwood Village tomorrow. Still open for people to attend, and can reach out to Heidi Onda, who's the lead for the White Ribbon Project, if you are interested in attending. And then Friday, they'll be hosting a lung cancer screening awareness event at the Skyridge Hospital in Lone Tree. So all of these are open to anyone. And if you want to learn more about lung cancer screening, great way to get involved and just learn a little bit more about the advocacy efforts happening, can join these events, or also visit the White Ribbon Project's website. So we will get those sent out to all of you again today, but take a screenshot quickly if you are looking to engage. So lots of opportunities to learn more about lung cancer this month, and really encourage your patients to get screened. So now I'm going to pass it over to Andy to further introduce our panelists for today and kick us off.
All right, awesome. Thank you, Elsa. And I know that we have about 60 people on the line, so super excited. And I think as we're talking about fall, today might be winter, so please forgive my hoodie. I have a nice outfit underneath here, but I am freezing. So I am excited that we have two clinical folks, leaders, thought leaders, as well as people who are an amazing advocate of the patient community, as well as really those who've really thought about how to help support team-based care, and really thinking about the roles of community health worker and navigator, who are going to be joining us today and who are on the line, who are going to be sharing some perspectives about outside of what we talked about for the physician's fee schedule, what's being stood up in Colorado for Medicaid. What are some really interesting opportunities to look at reimbursement strategies and sustainability of the navigator role. So I'm excited that Mary Kay Knode, who's part of Melissa Memorial Hospital in the Eastern Plains from Holyoke, as well as Dr. Linda Overholzer from UC Health Internal Medicine, are going to be talking about a couple different vantage points of how navigators have included in work, how the different systems, one in primary care, one connected to a rural hospital, as well as a larger health system in the metro area, really considering these strategies. Because I think as we begin to talk about sustainability, and we are talking about sustainability, not begin, because we've been doing it for a while, there are a number of ways. And I think what we're going to realize, and as time goes on, I think that we're going to have to look at a variety of opportunities to sustain the work and strategies. So in part of the work that we have funding from the state health department, other partners who have been really vested in implementing this work, we've gotten some really key and really interesting vantage points from these two individuals and others about what are some of these other sustainability strategies outside some of the direct reimbursement things that we've talked about so far. So I did get a call from Mary Kay initially saying she was really hoping to make sure she got to the event today because it was blizzarding, I can't say that word, in Holyoke and on the Eastern Plains. But it looks like, Mary Kay, you have made it, and you are in good stead. So let's kick off. Oh, Elsa, do we want to do some polls for today?
We don't have any formal polls for today, but
Okay.
we'll be asking you all some things in the chat as we go through.
Okay, through the chat. That's how we're, okay, perfect. That sounds great. I just wanted to make sure I wasn't blazing over something specific here. But we're going to kick off with Mary Kay. And Mary Kay, I know you and I have had some time through our work through the CCSP program, really thinking about sustainability of navigation in general. We've had some good times really talking about some of your approaches and where you've gone in terms of really thinking about the implementation strategy. So we're going to kick off with you. Mary Kay, would you mind sharing a little bit of the background of who you are, the work that you're doing, and then I know you have some slides that we can actually share because I think it's interesting that you have actually used some of the materials you're showing today to make the case to your C-suite that have really led to part of the initiatives around sustainability. So I'm super excited to hear, the material, how you've angled this, but let's just start out with chatting a little bit about who you are and then your investment in navigation and community health work.
Sure. Thanks, Andy. First of all, I'd like to thank you for inviting me. This is an opportunity that I love talking about. It's very close to my nursing and what I do. I am the specialty clinic director at Melissa Memorial Hospital. And as in any rural hospital, you wear a lot of hats. I oversee the behavioral health department. I oversee the patient navigator department. I cover the specialty docs that we have in. So I've got my fingers in a lot of things, and I love it. It gives us, we have a true advantage, I would say, in the rural setting because we're small enough that the coordination of care is very easy. It's much more attainable, I think, than it would be in a big system. There again, it comes with its challenges, but it's good stuff. This has been quite an adventure. We've been working on this. Jaden and I have been working on this for about 2.5, 3 years. And Carlos, who is our navigator, actually came to us and did an internship because he was getting his certification in interpreting. He came and worked in our clinic. Well, we saw what he was doing and kind of looked at it and tried to get him. We tried to tell him what we wanted to do. Well, we made the slide presentation in January. We hired him and he started May 1st. So this program's been going about 5 months. We've made a lot of strides there. The things that have happened with this department are very, very exciting. We knew when we started, Elsa, do you have the first slide?
I am working on getting them pulled up. It's giving me an error that I don't have access. So Andy and I are trying to troubleshoot.
While they're doing that, I'll just keep going. We set out with what our initial focus was, why we wanted to have, can you guys hear me?
Yes.
Yes.
Okay. What we wanted to accomplish. And the things that we wanted to accomplish is we wanted improved access to healthcare. We knew that our Spanish population, that we were not serving that population as well as we should have been. We wanted to increase healthcare awareness and screenings. We wanted a better understanding between the community members, the health systems, and also the social service systems. There again, increased coordination between community members and health providers, increase the use of the healthcare services, to help people understand the importance of keeping with the recommendations, the whole switch in the thought of giving care as to preventative and wellness instead of acute care and illness, which is very challenging. When you live in a rural community, You're dealing with farmers and ag people that don't go to the doctor unless it's an ambulance to the ER for chest pain. Or like with the Spanish population, they just don't basically go to the doctor at all. And the difference is that we found as we did this is because of the difference of what the medical system is in Mexico versus what the medical system here in the United States is. So those were some of the things that we discovered. So what we did, the first thing we did is we wanted to go out into the community. There were some established Spanish groups, community groups in the community. One of those was we actually started in our facility an English as a second language course. And we have our population of our environmental services staff is very much, it's almost all Spanish and all women, and they speak very little English. So what we did is once a week, we have a lunch meeting with them, and Linda Jeldon actually does a class of English as a second language for them. And it's really worked out well. And that the news of that has gotten out in the community, and which is a really good thing. And the other thing that happened is they found out that we care about what they say. One of the biggest obstacles to care that we found was understanding the language. We had the community, it's a board that kind of a committee that we formed with, it was business owners, it was the school, it was some of the larger employers from the hog farms, from Grainland, CHS, and we brought all these people to a round table. In that group was also a Spanish lady who had come to the United States. She'd been here 2 years, and she actually had her own business. The other one actually was working in a bank, and then the third one that was on the committee spoke very little English, and she was still at home with her children. So we had quite a varying group of people that were on this committee. Once we started asking the questions as to what the barriers were and why people did or didn't come to seek care at our facility, the first thing was the language barrier. So, and we knew that. So with having Carlos, that was very much taken care of. The other thing that we did is we now have, I think, 7 or 8 certified medical interpreters that are our staff members that are available, which gives us a lot of coverage. It really helps. So we took down the as much as we could with the language barrier thing. And then we started in the community. What can we do? Carlos went to the fairs. He went to Dandelion Days where everybody drives their old cars around and we live like we did in the 50s. He coordinated for our cancer walk this year. He coordinated a soccer tournament with the Spanish team members that played soccer when they were in Mexico. And we had 3 teams and actually had a soccer tournament for our cancer awareness. The other thing that happened this year, and which has happened with him, that he has been very instrumental in, is we do chemotherapy at our facility. And with the increase in the colonoscopies that we're doing, we're reaching the Spanish population. We are finding, I think we had 3 cases of colon cancer, and one of those was a young Spanish gentleman. This gentleman spoke at our cancer walk, and he talked about how important it was and how much it meant to him to have somebody who could explain things to him, help him through the whole journey that he had from chemotherapy to outside what do I want to say, resources. It was really, it was very touching. It was, you could see the impact that we were having. The other thing that we did is every 3 years, we have to do what they call a health needs assessment. Well, it was always printed in English. We encouraged everybody to do it. And this year we did it a little different. We actually had Carlos sit in our waiting room with an iPad. And as as the patients came in to either go to the pharmacy or whatever they needed, he would sit with them and explain to them what this was and why it was important that we had their input. This year, we had, I think it was 25 people, 25 Spanish-speaking people that participated in this community needs assessment. And that was a milestone. That had never happened before. And so we were very excited about that. We do a Wellness Wednesday. Every Wednesday, Carlos has done that. We have, he actually has a YouTube presentation that he does, and I think it's called, is it Mi Casa? I think it's Mi Casa on YouTube. So with the increase of people knowing that we're there, with the language barrier, we were able to get these people into our diabetic programs. We have a very strong diabetic program in our facility. And there is actually a class that we have on Tuesday nights, I think it's once a month or twice a month, that the instructor speaks, it's strictly Spanish for them. And in the Spanish population, diabetes and there again, wound care and all of that all goes together. So we're meeting with those people, we're showing them the importance of a diet, teaching them about diabetes and things like this. And this has been a very, very positive thing that's also happened.
Mary Kay, let me ask you a quick question, and I'm sorry,
Sure.
my internet's being a little wavy. I think in the time that you and I have chatted, you guys at Holyoke have received funding through programs like CCSP, where you have dedicated dollars through grant dollars to help support prevention, navigation,
Mhm.
build out a program. But, I think one of the things that struck me is that as you were really talking about, expanding services for more of an engagement approach, particularly in rural areas that could help fund, right, a position, that you had a community health work strategy to reach people who needed services who otherwise weren't making connection.
Yeah.
When you were looking at the sustainability and really thinking about funding Carlos's position, who've done amazing things with really the engagement, representation, and really thinking about this role. And I have to tell you, I'm not just hearing it from you. I've heard it from 5 to 6 different people in the Eastern Plains up to Greeley to Denver about all of the strategies and the way that you're working, as well as really the richness of, I think, how Carlos is really starting to engage. I think one of the things we had talked about a bit is really how you're funding this work and how you've been able. So Mary Kay, as you started to build this out and you were making the conversation with the C-suite about funding this position, can you share a little bit about how you have funded from prevention navigation in the medical setting to the extension of even so many of the great things? How has that happened for you all?
We actually created a position for this.
Mhm.
We used some of the navigation funds for our other interpreters, but we are paying for this position on our own. But with doing that, we also realized that we would be increasing services to our community. And if we could get those people, first of all, you had to develop trust with them. And if we could get them to understand who we were, why we were there, take down some of their fears, answer their questions, we knew that we could help them. And we figured our numbers alone would probably, with the increased visits, the things like that, that we could do for them, that's basically what we're looking at. Now, this program's only been in effect for 5 months. Have we really done anything as far as actually looking at what the numbers are as to how many we've seen? No, we'll go back and look when it's probably 6 to 9 months in to see what we are. But we, I don't know, Andy, it was the right thing to do. We needed to do it. And the reception that we've had with this, the way the community has embraced this, everybody knows about it. And there again, it's just not for the Spanish speaking. This is for other community members. And what the really nice thing is with behavioral health integration in the same office, you want to talk about a perfect setup. We had, and I'm jumping a little bit ahead here, but I want to share this story with you. We had a client for behavioral health who was struggling severely. And our LPC was like, what do we do? What do we do? Well, he talked to Carlos and he got permission from the patient. He said, you know, we've got this guy that could probably help you out. Would you mind talking to him? So Carlos did. He calls him on every Monday. He calls him on every Friday. He has his sessions with Cameron on a Wednesday. The phone calls have decreased. The stress level has decreased. This gentleman has moved out of his bad situation. He has started, he's thinking about starting a job, and it's a complete turnaround. And the reason I feel this happened is because he could tell that there were people that cared. You know, it wasn't, he felt safe. And that's what this is about. And it's reaching out and taking care of those people that need help. The other thing is there's people that may be struggling as far as the financial thing. We have financial counselors that if they're not eligible for Medicaid, we look at to see if they can be in our CICP program or if they can be on our same-day pay program. So it encompasses just about every aspect of the facility. Did that answer your question, Andy?
Yeah, and I think there's some comments, and I think what's really interesting is I think Mary Kay, when I've looked at, we've had some discussions about how did you really make the case, right? I think we really understand the impact, and I think understanding the work, but when you really had to talk to the C-suite and say, no, we pay for it, right?
Yeah.
You're not getting that from any other grant or foundational dollars.
No.
That's coming. So exactly how is the institution paying for that directly? Can you speak to, I think what we really want to focus on is really the component of how are you funding this position? And then how you've, really looked at funding the navigation position with some of the initiatives. But with all the great work that Carlos is doing, when you're saying you're paying for it directly, can you talk a little bit about where those monies come from?
It's directly it's a paid position out of our facility.
Okay.
He's a paid employee by us.
Okay, and those are facility fees from the hospital itself, is that correct?
No, it's actually a wage that he's on.
Okay, right, and and you guys are paying that from your operating funds?
Yes.
Hospital, okay, great.
Yes.
And then
Yes.
because I think what was interesting is when we have spoken, you also have had opportunities through other payers to support navigation efforts, right? In terms of, and do you want to, because I think one of the things is the impact that Carlos is doing and the work he's doing, it really was showing that proof of principle. So you made the case on some level for Carlos's position for the outreach component. And then what did you have to show your C-suite to make the position? Because I think really understanding that if someone's going to do this and they have to bring information and data, I think that's what folks are really interested in. Can you share a little more about that?
Well, we brought up the fact of evidence-based care.
Mm-hmm.
And we brought up the fact about disparities. And we pushed the whole thought of this goes on in northeastern Colorado, guys, and we really need to look at this. And we laid it out as to what a navigator could do and what we expected them to do. And I don't think that they had a real picture of what a navigator was.
Mm-hmm.
It's funny. I think a lot of people think that Carlos's main job is to be an interpreter in the clinic, when in fact his job is a lot more than that. The C-suite loves it. The community loves it. The C-suite's they've kind of taken it over and they kind of think it was their idea in the beginning, which is okay. That's okay. They're paying for it. It's all good. But it was just like the colon cancer, the increased patients that we've seen there, women coming in for their mammograms. It's just the increased services.
Right. And Mary Kay, you have talked about on some level, the health equity piece, but your team actually had specific quality measures too, right? That were really around, you talked about that assessment. Were there the other carrots that really helped? Because I think understanding the role of the navigator, seeing that need, but there were things that were really helpful, right? In terms of looking at specific type of metrics or any sort of quality indicators specific.
Yeah, I mean, and what we did is the first thing we looked at is our diabetic program.
Mm-hmm.
The next thing that we looked at and we're looking at is, or we will look at, is the number of increased visits by the Spanish population. The other thing that we're looking at is the number of people that he's been in contact with. Right now, I'm pretty sure, and Carlos, correct me if I'm wrong, don't you have about 35 people that you're navigating right now?
Yeah, that's correct. I don't know if you can hear me, but yes.
Yeah. So yeah, it's 35 people. And the indicators are leaning, I mean, we don't have the figures out yet, but I think the impact of this is going to be more than what people expected.
Mm-hmm. Great. And so I think, Mary Kay, one of the things that has struck me is I think when you had talked a little bit about, you've shown navigation to be successful from a number of initiatives that you've already had funded through grant foundational dollars, it really did help make the case for Carlos's work as a CHW role in really helping, make that case and then really looking at these quality metrics. And so Ashley has asked, and I think this is a good question, is in terms of tracking of those indicators, and you're getting ready to make the case because you got that investment. Everyone saw the proof of principle with other programs. You funded, Carlos to do this work. The engagement is definitely happening. And as you said, it's only 5 months, but I will tell you, I've heard rave reviews, right? And so we know that on some level, but I do think that, really where it comes down to is I think Ashley's questions is, what are those indicators that you're going to bring back to the C-suite that really speak to the bottom line? You talked about diabetes, component. You talked a little bit about connection to services, but do you have specific things that the C-suite is really asking you to measure?
As of yet, no. I imagine probably at about 6 months they will. They know the financial portion of what the reimbursement for this position is. I mean, the thing of it is with the patient navigator, they're required 60 minutes for each client that they see in order to bill. That's more than a chronic care management person. So it's I don't know. I think we'll take Jaden and myself and Carlos will sit down and we'll see between the three of us what we think the biggest impact was. And then we'll go back and we'll probably pull those numbers and do a study on them.
Okay, perfect. So I really appreciate this. And Mary Kay, one of the things I wanted to ask you too, and I just want to, is one of the things that you had shared a little bit is for the work even prior to Carlos and the team at Holyoke, you had actually looked at some care coordination, community health and navigation work that was connected to, was it a Medicaid or Medicare initiative that helped really with that work?
I'm thinking it was Medicaid.
Okay. And you really did look at an opportunity for that reimbursement and you guys were able to see those cost components. And can you share a little bit more about that perspective?
Jaden, are you on? That would have been done. That was done through the clinic, our family practice clinic. And Jaden is actually, go ahead.
I am on.
Thank you.
Yeah, so we actually have a chronic care management program, and that's actually a Medicare service, and we have two population health nurses. And Carlos works really closely alongside our population health nurses. And when Mary Kay and I were kind of thinking of this plan, our plan was to have them work in conjunction with our population health nurses to get a whole team-based care approach. And so the reimbursement model that we actually use for Medicare patients is we're actually with a rural health clinic, we're kind of running it under our care management services. And then Medicaid, we've worked with Colorado Rural Health Center and Medicaid recently to kind of talk about how our care management services and rural patient monitoring and our community health navigation kind of all has this team-based care approach for population health and patient navigation. And so that's kind of the model that we've used. And so we have like basically a population health team.
That's fantastic. And I love that you guys have really talked about the engagement. And I think that really shone through, Mary Kay, when we talked a little bit, prior to this meeting about how the Rural Health Center, Medicaid's really involved, and how you're building out a program that is with the hospital, the clinic system, and now with Carlos's work, really engaging that community. Because Jaden, it was my understanding on some level that really to be able to build out this support, showing that proof, and then really kind of I think on some level, Mary Kay, we had talked about that also. I think the hospital and clinic realized there are many folks that need the care in your community, but there's also a business model, right? Where there's a ton of people who otherwise weren't coming in to utilize the resources that could be. So it really did work well together. I have a couple of questions here, and then we'll pivot to Linda. The question is coming from how are you documenting about the patient outreach? And I think there's been a couple of questions in here about how are you using documentation from EMR, EHR systems, the outreach as well.
Carlos, do you want to answer that?
The
I'm
question
happy
is
to.
how we're documenting about the patient outreach.
Yes.
So the outreach that I've done and that I started doing once I started over here, it has been with different groups. So much as a log uh, of my activities with them. I have not developed one yet. As the position has kept on growing, I have keep getting invitations from different groups within the Hispanic community to go and speak with them and bring them in closer to the hospital. Uh, but as a form or something structured, I have not started that with that yet.
As far as specific patient cases, Carlos, you are documenting in along with the CCM, aren't you, in that same template on the EMR?
Yes,
Yeah.
I've started with that and utilizing the same code for coding purposes, the same that they use, G0511, if I'm not mistaken. I started with that 2 months ago.
And Mary Kay, this is exactly what it, now when you guys talk about the code, right, and what you're talking about, because you're talking about some level of reimbursement with that, correct?
Yes. Yes.
Okay, can you speak to that? Is that the diabetes component that you spoke of?
No, isn't this, Jaden, clarify it, it's a Medicare, isn't it?
Yeah, so the code that we use for a rural health clinic is G0511. And that's a general care management code. And Medicare kind of lumps that code all together for all care management services that are provided out of a rural health clinic. So FQHCs would also fall under that, but fee for service would have their own set of codes. And I think they're 9 codes. You would probably know, Andy. But so in the EHR, we have a structure. So we have a care plan template, and at the beginning of every month, the population health nurses and Carlos would then start documenting their time, a start time and a stop time with their interactions with patients. They document what was discussed with the patient during these times, what diagnosis it's related to. And then they, at the end of the month, have in the EHR a list of all of the interactions that they've had, how long they've spent. And then if they meet the time requirement, they develop that into a visit. That visit is then sent to the primary care provider to review and then is coded out with using that G0511 code. If that kind of helps with the workflow of documentation and coding.
I mean, I love me some code, so I have to tell you, I really, but I think Mary Kay and team, we're going to pivot to Linda because I think one of the things we can do, coming out of this series, we're creating tools and resources. This is really about some ideas, level setting, through the series, and then really jumping out after the holidays, into some real implementation strategies and getting to that next layer. I think working with your team, to really kind of understand where you started with these opportunities with Medicare, how you've worked with the Rural Health Center, how you've really helped lead towards making the case to the C-suite, as well as how you're really looking at utilizing some of these codes. I think these are some of the things that are really going to be amazing. And I know I'm getting some questions about how you're utilizing those codes. So Jaden and Mary Kay, we can be responsive to that on some level, because I do think as we move forward with the physician fee schedule opportunities, with the community health integration codes, as well as some of these codes that exist, how do we really utilize what's in existence and what's coming to really make the case? So this is beautiful. I think, as a rural health initiative, and I think with all of the things that can look different than I think what we're going to hear from Dr. Overholzer. But Linda and team, kudos. This is amazing. I know that the work you've really done to really look at a larger engagement strategy with your community is really quite amazing. I think if we can, maybe one of the things we've talked about is building out case studies about the art of the possible. So we'll be continuing to lift these up as well. Anyway, we'll have some more dedicated conversation. Jaden, if you can see the chat, there's a couple of questions about which ICD codes and which G codes are in there. And again, some of this I think we can build out in a larger case study. So with that, Dr. Overholzer, here we are. We moved from Holyoke to Metro Colorado. And I think, Linda, one of the things that I've really listened to as being a medical provider and hearing you champion the cause and really thinking about how you've seen the inclusion of navigation in the different models at UC Health and some of the things that have been implemented. I'd love to hear some of your vantage point, Linda, of things that have been effective and some of the things that we've chatted a little bit. So Dr. Overholzer, I'll turn it over to you.
Hi, thanks, Andy and Mary Kay. And Carlos, it was great to hear about the work that you're doing. Congratulations. So I'm a general internist at the University of Colorado in Aurora on the Anschutz campus. And so I think in a nutshell, and just in the interest of time, thinking about patient navigation and care coordination, I know my work with Andy primarily from doing cancer survivorship and cancer work, but I'm going to speak as a utilizer and a referrer to services from a general primary care standpoint. And I think as I hear Mary Kay talk and some of these questions come up and thinking about sustainability, and to clarify, I'm not the medical director in our clinic. I was not the one making decisions. It's all still a little confusing to me, but having been in practice for almost 27 years and in a kind of rural community setting and then coming to an academic center, these are some very recent changes that I think have been made that I think are helping to sustain efforts like patient navigation. So the strategy, I'm going to simplify it greatly. I don't know if you all are familiar with the terms like wraparound services, but I think that one strategy that our clinics have been using are related to coding. So that's a good segue, and specifically trying to capture the complexity of patient care, because all of us know that when someone comes in and sees a provider like me and you get literally a few minutes with them, but they've got all these social determinants of health and all these barriers to getting appropriate testing and referrals completed, and you're referring to different locations. There's a lot of, I think what drove this was the certainly reimbursement in primary care. But taking a deeper dive in that was that there is a lot of work that goes on outside of that clinic visit that's not reimbursed. And how can we create resources at the clinic, aka a medical home, and really help to address some of these barriers. So in thinking of the complexity of care, knowledge of this is that a couple of years ago, I think this started maybe in 2021 or 2022, I think there's an effort funded through HCPF, I'm pretty sure. And, as a clinic, we're always trying to meet metrics, right? So how many of our patients have their diabetes controlled? How many patients have blood pressure controlled? There's a whole list of them. And so those things are pretty easy to track. We're given metrics monthly as individuals and as a clinic as to how we're doing. But to reflect the complexity of care, and I think that this is especially pertinent at a place like the university where you may get referrals of patients that have more complex medical histories and have multiple specialists involved. I think this started as a pilot program, and it was you can get reimbursed, right, for justifying that you have a certain level of complexity of patient care in your clinic. And how is that documented? How do we justify that? So the most tangible way I can think to explain it is something that I had not heard of before a couple of years ago called hierarchical HCC codes, hierarchical care codes. So these are ICD codes, so diagnoses, but you can, there are certain codes that built in there are the assumption that there's going to be more complex medical decisions that have to be made. And so these would be like, for example, patients on dialysis or with transplants or certain chronic conditions. And it's not, I think when I initially talked to a couple of people about this, it's not a matter of trying to increase the fees, right? So that it's reflected for the patient. There's actually a very minimal impact from what I understand from the patient standpoint. But if you're documenting correctly, and as a clinic, if we meet a certain metric and we're justifying that we have this level of complex patient care in our clinic panel, then we can get funds to support. That comes back to us in the form of funds to support wraparound services. And what do I mean by wraparound services? It does include care management, longitudinal care management, and patient navigation. So patient navigation is kind of included in that bucket, although it's not specific to care management. It does also include behavioral health. It includes a pharmacy team that can help us manage patients who have diabetes, for example, and are having difficulties with that. So there's a whole slew of other services that it can help support our clinic to have those resources available. And those resources that are available look like there's a social worker in our clinic. There's now a behavioral health provider that is there full-time that we can refer to, and she can provide at least short-term management or provide assistance if someone needs longer-term management and needs help finding something in the community. And then we have a dedicated longitudinal care team. So if we have a person, for example, who due to their medical conditions or a combination of their medical and social determinants of health have frequent visits to the ER, for example, we can enroll them in longitudinal care management. And that person, they get referred to that person in our clinic, and they can help, make sure that if I wrote a prescription for durable medical equipment, that they've received it, or that they've, made their follow-up appointments. Certainly not specific to cancer, but that's where I became aware of it. I will say I had a chat with our social worker because I interact with them quite frequently, as I think most of our providers do. We have about 30 providers at our site. And she does work with a patient navigator. The patient navigator that I am most familiar with was actually a retired MD who is volunteering. What I can tell you about from the social work perspective is, she sometimes will be on the phone with patients for a long time, and sometimes, once a week or more. And she's pretty good about following up with, if she doesn't get a hold of them, she'll keep trying, so on and so forth. She does not get billed for that time, like a provider would. But I think that this funding creates salaried positions. And then just to kind of jump around a little bit with some of the chats coming up from the last presentation, we do, by having those positions and having them formally be a part of the team, we can create notes in Epic, for example. So I heard someone talking about transitions of care. We have a transitions of care template. So when someone gets discharged from the hospital, that's a transitions of care team, and there's formal documentation that has to happen, and a smart phrase and a template. And then, we're supposed to be seeing them within 7 or 14 days after they get discharged. There's notes that the social worker can write in the chart to kind of document what was discussed and what was said. And as far as referring to them, you get to know this team. It's a great team. These wraparound services, we can usually just send a chat message through the electronic medical record. Our social worker has been there in person. So frequently, if a patient's right there, I can knock on her door and ask for her to work with somebody. So I'll kind of stop there in the interest of time. I know that was a very quick overview, but I don't know if that's helpful or what you wanted to know.
Yeah, Linda, this is great. Let me ask you this, because the one thing that I think hit me when I learned of the work is really, I think what you shared is on some level, the build out of this wraparound team, right? With the bundled payment and the service. You have introduction of navigators, people who are doing types of services that really provide you as an opportunity as a doctor, right? To work at the top of the care, get more. I mean, what I've heard from you is you feel supported, patients feel more supported. What I also kind of heard from you, and this is me paraphrasing, please don't take these services away, right? Like building
Yeah.
out this team, it's
Yes.
working, it's great. You guys are finding. Do you have a sense? And I think one of the things I want to mention from today is, I think giving some overview of art of the possible beyond, some of the other reimbursement coding things we've talked about. That's really the drive home from today. I think we'll get an opportunity from Mary Kay and from Jaden to really spell out, right? How did you use the codes? How did that work? Some of the anecdote that we can about how it was developed. Linda, on some level, even getting a sense from you and the team about the build out for these case studies of how did you have this wraparound? What is it? Do you feel like what's being implemented right now, Linda, number one, do you have a sense if it's cost effective? And number two, if the institution can continue to support on this level, like with knowing how well it's worked from a provider standpoint, what's your sense?
So, we continually have to sing for our supper, right? So every year, you have to continually meet these metrics. So it's not like, this year we met our metrics and it's tiered, right? So if you meet a certain level, you get a certain amount of support, I believe is the way it works. So there's different tiers. We met the first tier. Do I think it's sustainable? I mean, as long as there's money through, and again, I believe this is coming through HCPF or other similar funding. I don't believe it's coming through the hospital, but you have to continually justify it. So I think from a provider standpoint, the complexity is always going to be there, right? Until we have better housing, until we have better access to food, until we have fewer transportation barriers and, the increasing survival and living with more complex medical conditions, the complexity, yes, I think that's going to be there. The strategy, I don't think I would probably be the best person to speak of as far as like, and I'm sorry, I don't have any, metrics or cost-effective data to show you. But I think as far as those funding sources are there and supported, and that's probably more on the policy side, then I think it seems to be very sustainable. I will say with patient navigation, I mentioned that the navigator that the social worker and us have worked with is a volunteer. And I know there's policy work being done. I was just at the NCCN, the National Comprehensive Cancer Network meeting, and I know they're doing a tremendous amount of policy work, advancing legislation to get funding for patient navigation as well. But so I think as long as those funding sources are there, this seems to be a good pragmatic way, at least in the clinical setting. And then with our social worker and our longitudinal care manager to kind of be our liaison with the community aspect pieces of this. So yes, to me, it seems like it would be sustainable. That's, again, coming from my perspective as a user and not the one who got this in place.
Yes, that is definitely, and I know there's still some follow-up that we're working, and I wanted to give two examples because I think we've seen, the vantage point of we have excellent representation from HCPF. We've had folks sharing information about the CMS with the PIN codes and CHI codes coming in, and then the art of the possible, right? And so what I want to say is I think it's still a little bit the Wild West here in Colorado as it relates to reimbursement. We are at the forefront as a state within the country of really thinking about how are we looking at in-hospital, in health clinics, in safety net clinics, like what are the opportunities? And I think we're going to keep the pedal on the metal. I really love that. I think the Holyoke Melissa Memorial team, as well as Linda, showing what's happening as one program, even at UC Health, that's happening, giving this idea. Again, I think what we hope to do is use this series from all of these things to talk about how are people implementing and what is the art of the possible. So I know I've received a couple of notes that people who had to hop off or people had questions. Can you get information about the previous sessions? Yes. Elsa will be sharing information about how you can share perspective and how you can have access to the information. But again, after the holidays, given some of the resources we have, some of our programs, some of our partners, we're really hoping to use some of the information to take that dive into further discussion around the implementation, the art of the possible, having multidisciplinary teams like we've had in this series really chat this through. And then Linda, Mary Kay, and Jaden, I think hearing updates, right, from you all about, hey, this is what we've used for those metrics. This is what we know from our business unit about where we're moving. These are the kind of things that we're really hoping to continue to highlight because, a lot of this is being built as it's being implemented. A lot of it is really looking at how we're going to continue these efforts because it's, it's going to take a lot of effort for it to continue on. But as much as we can use the Alliance and all the partners who are part of this for continuing sharing, that's really the name of the game. Linda, I think there was a question too, and actually someone had asked if the navigation services that we're talking about, and I can answer part of this, but I would have others chime in too, is if navigation services are community-based versus clinic-based, are they still open for reimbursement? What I will say right now is through CMS, and I think what's being stood up and some of the processes for Medicaid, there are opportunities. It's more about a partnership right now through CMS. It has to be someone who is contracted with someone who can bill, but there is an opportunity. And I know based on information that Elena and Morgan and team, we're really thinking about what is the art of the possible, but those are still really kind of being developed. I think what I heard from, Mary Kay and team is that even with some of the coding and working with Rural Health Center and some of the management teams with Carlos and Jaden, there's those opportunities. There's not a direct one-shot way to do that. But I think maybe in the case studies and things that we're putting out for additional information, we'll truly try to outline what is the opportunity of the possible as it relates to, in-service clinical settings, as well as what's happening in community-based organizations, because I know that's coming up a lot. And if you haven't had access to those service or those webinars, that's something we'll continue to post, so you can go back and view information about the CMS codes, as well as what our team and Medicaid and HCPF folks are doing in Colorado around the CHW reimbursement as well. I want to also just quickly say, and then have Linda, Mary Kate, and Jaden and team share anything else for closing. I do have a couple of folks, Becky Diorio, who is part of the CDPHE, who's really working on a lot of the workforce development, said that if there are continued questions as it relates to looking at the training and the certification or sitting for the assessment and the work, she's also available. But everyone, we are going to really be taking information from these sessions to really think about continuing this work after the holidays, to really taking about the next level of true implementation. So Linda, anything else in closing before we close down?
Oh, I mean, there's a lot I could say. Yes, you're absolutely right. I hope this doesn't go away ever, because I can't imagine practicing without that team around. I mean, it's just so important.
Perfect. Thank you
yeah.
so much. Mary Kay, Jaden?
This is kind of a new area for Northeastern Colorado. It's a different way of delivering care than what our community is used to. The benefits of it are very obvious. It's like you said, Andy, it's kind of like the Wild West. We're just starting. It'll be interesting to see where we end up. But the benefits of this, like I said before, it's the right thing to do. It's just figuring out how to pay for it.
Yep. And you guys have made enough of an investment, and it looks like you're well on your way. Great. Jaden, anything else to share? I think we're good. Okay, Elsa, as we finish out, any final reminders?
We'll send out, again, the links to all the previous sessions, and I also put in the chat, if you want to access them right now, the link to our overall folder for this series, where all of the slides, recordings, and materials are housed. So we encourage you to check those out, and we'll also send a reminder about the Lung Cancer Awareness Month events. So thank you all for joining today. Really appreciate the engagement, and we're also looking forward to sharing the results from the Alliance's survey we did with the CHW PN community in the coming months. So a lot more to unpack there with the landscape of this workforce in Colorado.
All right, thank you, everyone.
Thank you.
Bye, everyone. Thank you.